presentation. Dr. Avula, are you with us now?
I am. Good evening, everybody.
Good evening to you. And so you are the vaccine czar. I don't know if that's the correct title, but that's what I think of you for the state of Virginia, leading the vaccination efforts for the state, and was on a few weeks ago with the mayors and chairs, and I thought a very candid and great conversation. So we really appreciated it. I don't know if you're familiar with NVRC, but we're the Northern Virginia Regional Commission, made up of the localities of Northern Virginia, represented about 2.5 million people, and I think 35 or 40% of the state's GDP. We get together regularly. You had spoken with the mayors and chairs of the jurisdiction. This is the actual members itself, the membership of the group. And so we get together monthly and occasionally more often if necessary, but we're all delighted to hear what you have to say. And we're hoping maybe you could give us an update on the latest and greatest, and then maybe open it up to questions, if that would be okay.
Yeah, happy to do that, and glad to be here with you all. I'm a Northern Virginia kid. Grew up in Fairfax County, Alexandria, and Springfield. Went to TJ. Still come up there often. So let me kind of just tell you where we're at, and some of you may have heard this as I presented to local governments earlier this week, but we're just at 1.7 million vaccinations delivered today, and have had a big slowdown this past week, and that was really for two separate reasons. One, the severe winter weather outside of Virginia really nailed Tennessee and Texas and parts of the Midwest, where a lot of the distribution of Moderna was coming through. So we had 106,000 doses of Moderna that never made it to us last week. It has all been delivered now. And then the other part of that was the severe winter weather we had here in Virginia that ended up canceling a lot of our events. And so not only would we have worked through our backlog of inventory, but because a lot of those events were canceled, we just didn't make it up. And so our 7-day rolling average of doses per day went from 36 or so thousand doses down to about 30,000 doses. So that's starting to pick back up. We had a little over 40,000 this last, the last complete 24-hour period. And it also means that we have a ton of vaccine this week, because not only do we have that 106,000 doses from last week, but we also had another 160 first doses and about 100,000 second doses. And so really enough vaccine that we should start to see for the next week, 2 weeks and beyond, that pace of 45, 50, 55,000 doses a day. Our allocation has gone up again for next week. So the federal government is really delivering on its commitment, and every week we're seeing increased allocations into the state. Next week, it'll be about 180 first doses, about 120 second doses. And then on top of that, they've expanded the retail pharmacy program. So 2 weeks ago, CVS started up. They were bringing an additional 26,000 doses a week throughout the state. And then at the end of this past, we started this week with the new pharmacies. Another 26,000 doses have come into Virginia this week. That's being distributed through a number of different chains, and we can talk about that. But Walmart, Walgreens, Giant, Safeway, Food City down in the southwestern part of the state, a handful of others. So that's 52,000 doses per week coming in through pharmacies. We don't have control over it per se, but it does obviously add to the total number of people vaccinated in Virginia. We have asked our pharmacies to really focus on the 65 and up population. And so they're doing that almost exclusively, and that's good news because that's where our risk is. And then in addition to that, there is another thing that is coming through federally qualified health centers. And so that's particularly relevant for the Northern Virginia, because 2 of the 3 FQHC networks, and if you're not familiar, federally qualified health centers are networks of primary care clinics that are federally subsidized and serve an and underinsured population. So the FQHCs are neighborhood care or neighbor care, which is spread throughout Arlington, Alexandria, Fairfax, and Loudoun, and then the greater Prince William Health Center, which it has multiple locations across Prince William County. So we don't have numbers on that yet. I still don't know exactly when that will start, likely next week, but I don't know how many doses that'll bring in. But then in addition to all of that, so we're seeing these big increase in our total allocation of Moderna, Pfizer, new vaccine coming in through pharmacies and FQHCs. Johnson & Johnson, the FDA meets tomorrow to determine whether they're going to provide the emergency use authorization around that. Their initial report yesterday, some of you probably saw the headlines, safety profile looks really good, efficacy profile looks even better than we expected. And so I think all things point towards J&J being approved tomorrow, which means that Monday we'll be able to order Johnson & Johnson, and that would be delivered probably by Wednesday. And so mid to late next week, we could anticipate another 60,000+ doses of Johnson & Johnson. So this week, this right where we're standing right now, we have a ton of inventory, and next week that's going to get even bigger. And all localities are getting increases in their allocations. And so we should just see a lot of work through those pre-registration lists. We should really put a dent in the list of folks in 1B who have been waiting. Where does this lead us? I think that realistically by the middle of April, so probably 6-7 weeks from now, we should really be able to get through all of the 1B population. And so I think as you continue to hear from constituents and you continue to hear people concerned about, when am I going to get vaccinated? The core message that I think you can share with confidence is that we're now seeing supplies where we can churn out 50,000 doses a day, and everybody in 1B will be able to get vaccinated, at least with their first dose by the middle of April. So that's really encouraging, and we're adding new channels every day, new providers that are coming on, getting more and more doses to primary care because they have been waiting very patiently to get access. Hospitals are starting to get larger amounts now that we've got supply. And so I'm pretty excited about what'll come over the next couple of weeks. I think we'll really hit sort of what we saw at the end of January, where we had 4 straight days of 50,000+ dose delivery. I think we'll see that pretty consistently for the next couple of weeks. So let me stop there and see what questions that generates for y'all.
All right, a lot of good information. I'm going to go ahead and open it up to questions. If you have a question, you can either raise your hand. I see one right on the screen. Probably better yet, Mr. Sains. But after we do that, if you have a question, why don't you just put it in the chat? Sometimes I don't see all the hands for some reason or the other, but if you can you can either ask it yourself, or if you want me to ask it, I'm happy to do that as well. But let's start with Karan, and then we'll go to other folks from there. So you're up.
Thank you, and thank you for that update, Danny. Just to clarify, when you say 50,000 a week, is that for our region, or is that for what area exactly?
Sorry, yeah, that's that 52,000. Well, depending on what we're talking about, but the 52,000 for pharmacies is for the entire state.
Okay, pharmacies. Okay.
Yeah.
Okay. So CVS, the Safeways, and
Correct. So let me just recap the different channels. So for next week, 180,000 first doses, 130,000 second doses, 52,000 doses from the pharmacies, 60-some thousand doses of Johnson & Johnson if all goes well, and then an additional allocation for federally qualified health centers. So that's 310, 362, and then 420. I mean, we're talking about 420 to 430,000 doses next week for the state. Okay. In comparison to like 100 and let's see, last week we were about 220. So it's a massive increase in total number of doses.
And then last question. So do you feel, and it sounds like the answer is going to be yes, but do you feel that moving forward, every region or every area is going to be definitely getting a lot more doses than what they were then receiving? For example, I'll be selfish and say Loudoun, for up until recently, we were only getting around about 4,800 doses, where we could do close to 7,000 a day. So are we going to be seeing those increases moving forward?
Yeah, so Loudoun will jump up to at least 6, and I actually just was talking to Dr. Goodfriend yesterday. I think there's another tray of about 1,200 doses. So it will almost double, and I think that's true for almost every locality in Northern Virginia. We'll see a big increase, almost double.
All right, we've got a couple more questions that have been coming in. This is from, actually, I'm going to let her go ahead and ask her own question. Julie Brissman, you're up, followed by Supervisor Bailey.
Thank you, and thanks for joining us this evening, Dr. Avula. We really appreciate it. I had actually 2 questions. Following up with what Supervisor Sains was saying, Loudoun County was we got excited when we heard that the 16% and then 23% increase in doses, but we were stagnant at 4,800 until this week when we were bumped up to 5,600. So are you saying by next week we should be getting double?
Yeah, I just put in an order yesterday for another 1,200 doses, and then the allocation team is actually meeting right now to finalize total allocations for next week. And then the Johnson & Johnson will add a big bunch, a big infusion to that. So I think Loudoun's for next week will look more like 8,000 plus.
Oh, that's awesome. That's really good news. And then I had a little bit of a question about, and I think some of our constituents are also a little bit confused. We're getting federal doses going to pharmacies and, you know, grocery store pharmacies and that sort of thing. And then we have the state allocated doses that are coming through, you know, the state health departments. I guess a two-pronged question. First of all, do you see the federal allocations kind of eclipsing eventually the state allocations? And then kind of along those lines, should people kind of register for both and just wait to see which one comes in first? Or should they just register for one or the other?
Yeah, so when you say both, Julie, are you talking about the state pre-registration system and like pharmacy registration systems?
Right. Well, it's my understanding that you have to register through the state and that you would get from the state health department. But if you registered with like CVS, then you're getting the federal supply.
Yeah.
So yes, should people try to register at both places? Or
yeah, and I think that's primarily what people are doing. You know, we wanted to keep it as streamlined as possible, but didn't have that option with CVS. With the federal allocation, you know, they basically said, listen, we'll do 65 and up, but we're going to register people through our own online platform. And so they're opening up appointments every couple of days. And basically it's a first come, first serve to whoever can get to those appointments. These additional 26,000 doses that came through the retail pharmacy partnership, Albertsons, which covers Safeway and one other grocery store chain, but Safeway is probably the most relevant one up in Northern Virginia. They are also doing their own independent process. And so what we are going to do next week is we'll basically have a map embedded on the state health department website that says these locations have their own independent registration process. And here's the link to that. Everybody else will work through the state pre-registration process. So, for example, the other pharmacies, Walgreens, who else did I say? Walmart, Publix, the giant grocery stores, which are run by RBS, Food City, they have all agreed to work with the health departments and work off of our pre-registered lists. So, you know, there's a little bit of variability there. And honestly, like, I would say 2 to 3 weeks from now, we will probably just let them open it up because it is a massive logistical undertaking to like curate these lists, either have the local health department do the calling and scheduling or have the pharmacy doing the calling and scheduling. We're using the call center for some of that right now, but just the way that the lists are defined and there's a lot of confusion that I think is not only creating confusion for people on the ground, but creating a lot of frustration for an already pretty sapped public health workforce. And so I think the easiest and best thing to do is just to tell all of these people who are getting their own allocations from the federal government, use our priorities, do our 65 and up, do our 16 to 64 with underlying conditions, but go ahead and schedule them the most efficient way you can. And because we are at a point where we've got so much vaccine coming in next week that, you know, I think within a few weeks, everybody's it's going to feel really different. So this idea that I can't get vaccinated is going to feel really different because there will be a lot of opportunities to get vaccinated.
That's great news. Thank you.
All right, so we've got a few more questions. Next question is Supervisor Bailey.
Can you hear me?
Yeah.
Yes.
Okay, great. I had a comment. I just wanted to say that I'm glad that you're having those weekly meetings for us. They've been most helpful on the Wednesday nights for the supervisor. So thank you so much. We really appreciate that. And then the other thing that, and you may have mentioned this already, and I may have lost it in the shuffle, but are we looking at expanding the opportunity for other locations to distribute the vaccinations, like the churches, you know, larger facilities, so that when we do get enough vaccines, it's available? What does that look like?
Yeah, we right now are really looking to expand all of the different places. Now, some of that will happen through large scale vaccination, right? So the health department or a health system can do double or triple what they have been, and they just haven't been able to do it because they haven't had the supply. We also are looking for, doctors' offices and other independent pharmacies that are set up to do this, that have gone through the CDC requirements to receive vaccine, that know how to do data entry. And then we will look to do mobile clinics or clinics in different congregations and different settings. Now, the only caveat there is that you can't just give a bunch of vaccine to a church without them having a clear way to store it, a clear way to handle it, and then a clear way to do the data entry. And so if a church wants to be a vaccine site, and there are many, many, many churches that have offered to do this, and it makes a ton of sense, right? Like, both because particularly when a pastor says, hey, this is important for our community, let's do this, that carries a lot of influence, and we're going to have higher uptake in communities like that. And so we want to leverage that relationship. But actually doing it on site in a church just means that you've got to work out the logistics. And that's happened in some parts of the state. I mean, I know down in Chesapeake and Norfolk, there have been Danville, there have been some good examples of large congregations where they've been able to get 1,000, 2,000 people through in a day. So I think there's all of those variables of the logistics of vaccine, making sure you have the vaccinators, making sure you have the enough space and staff to make it happen. So I mean, I guess I would say, your local government and your health department are going to scope out a bunch of places. I know, sorry, I didn't catch where you were from, Supervisor Bailey, but I think that there's clearly just a lot of coordination happening in different locations right now to get vaccine out to different communities.
All right. So we've got a question that just come in. I'm going to go ahead and ask it. How confident are you that VDH can handle this surge in the weekly doses? Are you guys scaling up? Are you fully capable to do that? And do there need to be increased communications with the fact that there's going to be so much more vaccine out there?
Yeah, well, I think the key here is that this is not just VDH. Like, while we control the distribution, the number of providers who are receiving vaccine is increasing immensely. So not only will the health departments get more and the health systems get more, but there'll be 100 additional pharmacies and providers who will now have vaccine that they can give to their patients. And so I think a lot of our health directors, particularly the ones that serve your areas, rightly so, are saying we have got to focus on the most vulnerable, our 65 and up, our Black and Latino populations. Those individuals have severe underlying conditions, right? Because from the public health perspective, it is super clear who's at high risk for COVID complications, and we should be unwavering about how we prioritize those communities. The challenge is that there are these simultaneous priorities of those high risk health conditions, but then also these essential workforces that we want to get back to work, our teachers, our childcare workers, and kind of the fear and concern that has surrounded some of the decisions to go virtual. And so we've got to do both of those things. That's been extremely difficult through the month of January, but it's gotten easier through February, and now it's really gonna explode. So it's not just VDH that is having to scale up delivery. It's maximizing all of these different channels to get the vaccine out. And then from a communication standpoint, I certainly am open to, because you guys obviously do a lot of communication with your constituents. If you have thoughts, ideas of what we need to do in addition to our partner updates, I do 1 or 2 press conferences a week. The governor also does one. And I try to stay pretty connected to to local news and print media, doing multiple interviews per week, but really open to any suggestions you all have about how to get the information out there.
All right, great. We've got another question that I'm going to go ahead and read. Who has control over where the CVS distributions are placed? In other words, to a lot of us, it just seemed like here it is, as opposed to this is a minority population. This is a, whatever it is, we want some assistance or some input on where they are, these pharmacies. Now, given the broadening out of the pharmacies you just described, maybe it's going to be less of an issue, but could you speak to how the particular pharmacies were chosen?
Yeah, so with CVS, they came to us initially with 30 different stores around the state. And then we in turn turned those to our health directors and said, hey, does this seem to have good coverage in your community? Does it provide good access to vulnerable populations? We also ran it through our state level health equity working group to make sure that it met some of those equity metrics. We sent that back, and there are probably 6 or 7 stores that we recommended changing. And CVS did 5 of them. Some of the considerations that CVS had to take into consideration: one, any of their stores that were used as depots for their vaccine for their nursing homes and assisted living facilities, they didn't want to double up their inventory in the store. It just gets too hard to track. So some of those stores were taken out of consideration because they were already being used as hubs for nursing homes. And then some of their stores, just like they're called health hubs, and they have better throughput, better ability to maintain social distancing, and a better system to get 100 people through in a store a day. And so, there was a little bit of negotiation based on how do we get to the right populations, and then how do we also optimize the footprint that your store has. But CVS started 2 Fridays ago. And what will happen is that as we get to 3 and 4 weeks out, when they get their second doses, they're going to start expanding stores. And so we've definitely provided our input on how to get, and if you guys have ideas in your own communities about where you want to see that, either you feel free to contact me directly or route it through your health director, and we'll absolutely advocate for new stores to come online. But please know that when we onboard these new pharmacies, we're really thinking about not just like geographic distribution writ large, but are we putting this in communities that need better access to vaccine?
Gotcha. So our next question is from Matt DeFerranti. I'm going to recognize Matt. Are you there, Matt?
I sure am. Thank you, Mr. Chair, and thank you, Danny, for trying to be everywhere on Zoom all the time. There's been a little more push and guidance in 1B on 16 to 64 with underlying conditions. And I kind of wanted to just, we got guidance. Everybody is interested in the vaccine yesterday. So I guess it just accentuates the point that Mayor Wilson has been making, and that you alluded to, that if you look at the last parts of 1B and 1C, discerning between who should go first in that seems really, really difficult. So, with the doubling, it's just sort of trying to echo the point that if you look 4 or 5 weeks from now, it just seems to me to accentuate that, you probably want to open it up at that point, because, saying that legal services goes after media and food service goes after construction, I don't know if you've had any more conversations along this line.
Yeah. Well, you started with okay. So the idea that 1C just seems to sort of blend into everybody else, right? I think that, personally, I think that's very true. I think there are obviously members of 1C who feel like they've been prioritized for a reason, and to some degree they have. You think about your energy infrastructure, your air traffic control infrastructure. I really think, Matt, that we will be at a point, sort of towards the end of April, where we're starting to think about transitioning into 1C anyway, where supply will no longer be enough of an issue to really split hairs between 1C and the general population. Now, if something catastrophic happens and production drops off with Moderna and Pfizer, but we will also at that point start to see AstraZeneca come on board. And so, my gut is that we're going to have the supply through so many different channels that we're going to be able to open it up to everybody. But we will just have to monitor and see if that continues, if the production keeps up and that continues to be the case. I don't know that we will need to make a policy decision about that for a couple more weeks.
Thanks, that's helpful.
Hey, next question, Dahlia Palchak.
Yeah, thank you. Really good to have you here, Dr. Avula, and yay, go TJ in Fairfax. So a couple of questions for you. Specifically, as you know, in Fairfax, we're still doing our own program with IT. Really appreciate, you brought in much more increased communication and coordination, and that means a lot. I know there are a lot of unknowns on your end, but as quickly as you're able to communicate with us, the easier it is. Appreciate that you're bringing up the equity issues because that's absolutely, on Tuesday, we are bringing in our Chief Equity Officer with our health department to talk through that plan. A couple of questions and concerns, echoing what was said about CVS. It's my CVS, but I don't know that it's the CVS in the best location for what our community needs. So that's absolutely a concern. I guess what I would love to know is, as you're sharing, want to confirm what you've said, that by mid-April, you expect 1B to be fully vaccinated. And is that across the state, including in Fairfax's portion? And let me ask you number two, really hoping that we're able to remain on RAT system through 1B, so that if there are going to be changes, that we have the adequate time to work through those and get paired up with the state.
Yeah, I mean, I think that, you know, our ongoing conversations with your health director and your county manager, we're open to whatever they want to do, right? If it's working to have parallel pathways, totally fine. What we would do is anything that comes into the state pre-registration system will just get ported over, so that those individuals who, you know, may be registering in both places, or maybe only got the memo to go through the state pre-reg system, that'll be ported over on a regular basis. So, you know, the idea there is that no one will get lost. Whatever channel they're coming through, they'll get ported back to Fairfax. And then if Fairfax decides that, you know, that enough has been smoothed out with the pre-registration of the state, they like how it's working and they want to integrate them, we're ready to do that as well. So I think the medium we found is working fine. I'm not sure that, I mean, you'd know better than I if it's creating confusion amongst the residents in your community. So if the county decides that they want to keep that through the end of 1B, that's totally fine with us. As it relates to, you know, the timeline for us to get to 1B, I mean, this is really based on kind of sketching out the numbers. You know, we know that we've got about 6.5 million adults. We want to get to about 75% of that, and then you start to take the one dose, the first dose of that proportion of the population, and based on the increasing amounts and the projected supply we're getting, that's how I'm coming to the middle of April. And so I think that's true statewide. We'll continue to kind of shift around vaccine to make sure that you know, we don't have communities that are getting way ahead on 1C or phase 2 while we still have 1B in other communities. So what we have been doing, and I think what we'll continue to do, is sort of slight tweaks each week with the distribution allocation to make sure that the 1B demand is getting met.
So you just scared me with slight tweaks. As you may know, our supply went down quite a bit when the state changed from the original distribution to the per capita. We had a much lower supply, which makes it harder for us to plan, right? So
Yeah.
I guess.
But we should be clear about why that happened. I mean, it's not like we had said, hey, Fairfax, this is your proportion that you get. It's that at that early stage of vaccine distribution, Innova and Fairfax Health Department were the ones who had the capacity to get it, right? And so because they had large scale and ultra cold storage, like they were probably the first 3 weeks of vaccine distribution, it just went wherever who could take it. And so the drop wasn't like yeah, so like obviously it felt like a drop because it was less than Fairfax had received for the first 3 weeks, but there never should have been, there was never a guarantee or the plan that would continue to be the case. And I know that was super frustrating for the health department, for Innova. I mean, I navigated a lot of that, and obviously ultimately for the residents of Fairfax. But I do think it's really important to state that the hospitals were getting a lot because that's where the healthcare workers were. That's not what should have driven allocation at that point. Moving forward, again, unless something catastrophic happens, we should not see drops at all. And so, you know, in Fairfax this week, your guys' allocation went from, I think, like 14,000 to probably 26,000. So a huge jump for Fairfax. And it won't be a huge jump like that every week, but it will. We will not drop allocation. So people will have a 3 to 4 week planning window where we know we're getting at least this much and can move forward on that.
I appreciate that. Planning is so helpful. So
yeah.
How about those Fairfax numbers?
Do you have over 1 million residents?
Hey, we're ready to do 7,000, close to 7,000 a day, Doug. We can get them out.
All right, you're on.
We do have some more questions. Let me ask one or two just clarifications. So when you said mid-April, that's based on assuming not everybody in 1B gets vaccinated, but approximately 75% will take the vaccine?
Yeah, the national data is actually less than that. Like the national surveys show that about 30 to 32% of people either definitely will not or probably will not receive the vaccine. So I'm being a little optimistic, thinking that we can get to that 75%, threshold for herd immunity. I think there's a lot of great work happening through, doctors' offices, through health department efforts, through church congregations to really provide good information and help people maybe change their minds. I also, this is not super optimistic, but I do think that the emergence of variants in this country will likely drive more people who may not have considered it before to get the vaccine. So yeah, I'm ballparking based on 75%. And frankly, there's a more educated and more likely population in Fairfax in general that would be more what's the word, more likely to get the vaccine. So
Sure.
So I think 75% is a pretty reasonable target for you all, especially.
All right, so we have another question about the CDC and records. The question is, I assume the CDC has all the records of who's been vaccinated, when, and with what. Can you talk a little bit about how that works, how the records work and the like, and who's keeping track of what?
Yeah, so all of this information, when somebody gets vaccinated, goes into a state database called VIS, the Virginia Immunization Information System. And every state has their own version of the IIS. And all of that feeds up into the national database. And so the CDC does track it. Obviously, we track it as well at the state level, but that's the repository for everybody who has been vaccinated. The CDC also does track adverse events. So there is a active surveillance system called VAERS, the Vaccine Adverse Event Registry System. And anytime something happens, and there's kind of two ways that information gets to VAERS. One, people who get vaccinated can download something called vSafe. It's an app that the CDC created, and they can just enter in their own symptoms like, hey, I had hives, or I was itching, or whatever. And that's one pathway to the VAERS system. The other is through providers. So if you have a more severe reaction, or you report a reaction to the nurse on site or to your own provider, they will enter that into the VAERS system. And then the CDC monitors that across the country. And so when there is a situation where, a certain spike in types of adverse events, the CDC will look at that and say, okay, are there certain subsets of the population who maybe shouldn't receive the vaccine? Now, remember that this was all tested at the tens of thousands of people scale, right? Moderna had 36,000 people in their trial. Pfizer had 44,000 people in their clinical trials. So they were already tested on a pretty large scale, but now we're talking about the multi-million scale in terms of doses delivered. And so there may be things that are rare that show up that you see, and as the CDC gathers information about it, it will adjust its recommendations if it needs to.
Okay, great.
Chair, could I follow up, because I had a little more on that question, if that's okay?
Sure.
Thank you, Dr. Avula. Thank you so much for doing this. Yes, you're zooming around everywhere because I see you all the time. It's great. Thank you. And part of what I was getting at with this question was, I understand the CDC is, they're getting all this information, they're doing all kinds of great stuff with it. What if we on a local level down the line need to know who's gotten vaccinated, whether by CVS and what they've gotten in case something comes up, some strange variant. So, I mean, who knows what, but we might need to get information back out of the system. And that's what I was wondering about, is that, will we have that capability?
Yeah, at the individual level, yeah, all of that individual information is in the Virginia IIS, the Immunization Information System.
Whether it's CVS or no matter
Correct.
who did it.
It all feeds, and that's a requirement. Like, you can't get vaccine if you're not entering into Viz. So any provider that receives vaccine has to enter their information into Viz and has to maintain inventory on something called Vaccine Finder. There, and this is why, earlier when I was talking about you can't just give vaccine to the Moose Lodge. It's because of these types of requirements. They have to prove that they can store the vaccine in a safe way, that they can handle the vaccine in a safe way, they can administer it in a safe way, and then they can do the data entry follow-up.
Excellent. So we're going to be able to pull our data if we need it at some point, or you can push it out to us. I mean, I assumed that was the case, but lately my level of trust has gone down a little bit in our whole national system. Thank you.
Yep.
Thanks.
So, but HIPAA doesn't prohibit like disseminating that kind of information to local governments, just out of curiosity?
Oh, it absolutely does. So, I mean, I think if you guys are asking for individual name level data, that would be challenging. Like, there'd have to be, and we're in the middle of a public health emergency. And so a lot of that, the state health commissioner ultimately will have to just make the call. Like, are we going to give that individual level data? And I think, if there were a severe enough circumstance, we would do it, right? We'd get a waiver for HIPAA for that. On aggregate level data, then we can just sort of analyze, this percentage of Arlingtonians have been vaccinated. Here's how it breaks down. So that's a lot easier to do. But yeah, I mean, I think it would have to take a pretty unique circumstance, and ultimately the state public health commissioner decree to do individual level data.
Got it. So we are open to questions and comments from folks. And while we're waiting for the next one, I will be respectful of your time. I'll let you go here shortly, but it's of such importance to the group. Can you speak to the question of these different vaccines? Let's say a month from now, there's the J&J, AstraZeneca, Moderna, and someone walks in and you say, okay, here's the J&J vaccine. Well, it's only 71% effective. I want the Moderna vaccine. How is that going to work with people and which one they want, and you just take what you get? Sorry, that's the way it's going to be? Or what is the plan when there are multiple vaccines that have different efficacy rates?
Yeah, well, I think the first key is that there's total transparency, that people know what they're signing up for. And so the way that we're starting to think about integrating J&J into our allocation is that in terms of how it goes out to different communities, it'll just follow the same allocation methodology, sort of population with these different weightings. But I think the guidance that we're giving to providers is that you want to make sure that the patients know what they're signing up for. So if we do a mass vaccination event, we'll do a Johnson & Johnson event, and anybody who we sign up will say, just know that this is the Johnson & Johnson vaccine. It's a one-dose vaccine. It's incredibly safe. It's very effective. And here's the information about it. And then they get to make an informed decision about if that's what they choose to do or not. Because people are going to come with all sorts of different reasons, whether it's one dose versus two doses, whether it's 72% versus 95%. I mean, I think the key messaging for us around Johnson & Johnson is that the things that matter most, death and hospitalization, 100% effective, right? So from our standpoint, from the public health standpoint of minimizing morbidity and mortality, Johnson & Johnson is as good an option as all of the other candidates. And has the added benefit that it doesn't need to be frozen, and it's only one dose. So obviously the efficacy around the 70, 72%, wherever the data will end up, will be a question in people's mind. I think we have to do a really good job of explaining against serious disease and against hospitalization and death. It's just as effective, 100% effective against hospitalization and death. And that Johnson & Johnson was like, those trials happened at a different time in the course of COVID, right? There were likely variants that played into that Moderna and Pfizer didn't have to deal with as they were going through their clinical trials. And so, again, from my perspective, it's just as good an option as the others. And I think most of the health and public health professionals would agree.
Got it. But still for the public that I think will have different opinions on that,
Yeah.
They will be able to be told, like right now, the only game in town are two that are very comparable. But in the future, there will be, it's a disparity. It's a notable disparity. And so people will be told, you're signed up on this day for this vaccine. Is that right?
Yeah,
Right,
and what they
state?
won't have necessarily is a choice, right? Like, we won't be able to say, hey,
Sure.
we've got this clinic, and this clinic, which one do you want? What they will have is full disclosure about, hey, for this mass clinic, this is a Johnson & Johnson clinic. If you want it, great. If not, you'll keep your spot on the list for a future event.
Got it. right, so we have another question, Supervisor Angry, and I can either ask it for you or you can ask it. I guess I'm just going to go ahead and ask it. The push for clergy and pastors being as a priority on the list. Can you speak to that?
Yeah, so obviously there have been a lot of pastors who are and clergy that see people every day that want to get back to their very important roles in supporting their congregations. And so what has been the case up until recently is that any clergy member that falls into one of the other categories, for example, if they're a hospital chaplain or they're doing a lot of hospital visits, that would put them into 1A. If they worked kind of in mortuary services or somehow were able to justify under that particular category, that would put them in 1A. Many pastors would or clergy members and faith leaders would fall into 1B just based on underlying condition or potentially age. But now that they are actually being included, if you look on the VDH website, they've been added to the 1B category as well. And so that I think, again, some people had already been doing that, sort of classifying them as human services workers, which are a 1A category, just based on the types of visits that they're doing, the counseling visits that they're doing. So now they're in 1B, and again, I don't think that will significantly change the timeline for us to get to 1B. And really, at this point, we're talking about 6-7 weeks before that entire bucket gets to be vaccinated. So I know it's been a long road waiting for vaccine, but I think things will go pretty quickly, and the feeling of not being able to get vaccinated will start to go away pretty soon here.
Got it. Okay, so I'm going to call for last questions. I do have a question from someone who's already asked one, but is there anyone who hasn't asked a question yet who'd like to ask one before we start wrapping up? All right, if not, there's a question. Libby, do you want to ask that yourself? Or do you want me to ask it for you?
I'm fine to ask it. Just
all
very,
right, go for it, Libby.
Yeah, thank you, Dr. Avula. So I've just heard recently that if you've had COVID, and a number of people in that you'll need a booster shot, most likely. Do you know anything about that? And maybe you just don't know, and it's not a good time to ask that question yet.
Yeah, so right now the guidance is that if you've had COVID, you're good to wait at least 90 days, right? You've got naturally occurring antibodies, and you don't need to necessarily jump to the front of the line if you qualify through some other eligibility criteria. If you have had it, there is emerging data showing that you may just need one shot, because as your body has already developed antibodies, you may just need that one shot as a booster to rev up antibody counts for any future exposures. So that's not the formal recommendation yet, but I would guess, Libby, we're probably a month or two away from there being enough data for that to be the formal recommendation.
Thank you. That's helpful because that's something else to plan for. Thank you.
All right, and Dr. Avula has put his contact information in the sidebar here, the chat bar. So we thank you for that. And I tell you, I know you've been making the rounds, and so I don't think we're going to keep you anymore tonight. But once again, on behalf of all of us in our communities, we thank you for the great work you're doing, and Godspeed with what you're working on now. So thank you.